Okay, let's see if we can wrap up our discussion of the first mind-body problem today so that maybe by the end of Wednesday's lecture we can have had something to say about the other three. And just to kind of begin here, let's talk about a way out of Descartes' impasse that has been discussed a lot by Professor Searle. And the first point Searle wants to make is that the mind-body problem is with us only because we think about the mind-body problem in a particular way. If we think about minds and bodies as separate things, as separate substances, then we're led straight into Descartes' impasse. We got to figure out what kind of substances and how they relate and all that. But if we break out of received categories and think about consciousness in a different way, maybe we don't confront Descartes' impasse at all. So what Professor Searle proposes as a method for modern psychology is to say, first, let's figure out what the mind does. Okay, let's start there. And then once we figured out what the mind does, then we can figure out how the brain does it. Notice that the assumption here is that the brain does it. Okay, that's the answer. And then the rest is, in a sense, detail. But it's the kind of thing that neuropsychology and neuroscience and things like that are, in principle at least, set up to figure out. So the first thing we have to do, if we're going to start by figuring out what the mind does, we got to figure out what we mean by consciousness. And the point here, we talked about this a lot the last couple of lectures, is that there are different definitions of consciousness, and different definitions will lead you to look for different kinds of correlates. So, for example, in Searle's own book, he talks about consciousness in terms of about 8 or 9 different kinds of properties of consciousness. We can think about consciousness in terms of subjectivity. We can think about consciousness in terms of attention. We can think about consciousness in terms of feelings of pleasure and unpleasure. How we define consciousness is going to determine what we look for and what we find in the brain. A similar list was offered by our linguistics professor, George Lakoff, much the same way. If you define consciousness as attention, you'll look for its neural correlates one place. If you define consciousness as metaphor or empathy or something like that, you'll look for it someplace else. Here is a more recent, the approach to this comes from a Belgian neuroscientist named Steven Loris. I'll talk about him a little bit more when we talk about anesthesia and coma. But he's argued that there are 2 fundamental dimensions on which conscious mental states can be arrayed. A dimension of awareness, that is, whether you're aware of things going on around you or not, and a dimension of wakefulness, that is, whether you're awake or asleep, and that various states of consciousness can be arrayed in this two-dimensional space. But what you might do is take some phenomenon like coma or general anesthesia or drowsiness or whatever and figure out what its neural correlates are, and that would give you a hook to figure out how or what part of the brain is critical for consciousness. So, for example, we have this very dramatic neurological condition known as coma, which appears to involve a loss of consciousness. The patient has his or her eyes closed, they're unresponsive to external stimulation, there are no signs of emotion, they're breathing, their heart rate is intact, but they seem to be perpetually asleep. So these are patients who are, by all standards, unconscious. That is, they lack consciousness. And you've got this group of patients who don't have this thing you're interested in, and what you want to know is, where's the brain damage? Well, it turns out in coma, classic cases of coma anyway, the brain damage is in a particular area known as the reticular formation in the brainstem. Damage to the reticular formation produces coma. Okay, that's just what it is. Okay, so now if you want to start thinking about what part of the brain produces consciousness, If you think about consciousness in terms of whatever it is, whatever state you're in when you're not comatose, then you know that the reticular formation is somehow critical for that. That's the logic here. There is another syndrome that is somewhat similar to coma, known as the persistent vegetative state. You can think of this as kind of one step up. When you recover, when people come out of coma, they will frequently move from coma into this persistent vegetative state, which can be defined as wakefulness without awareness. Patients in the persistent vegetative state seem to show something like the normal sleep-wake cycle. Their eyes will be open for a while, and then their eyes will close for a while. That's not the case in coma. In coma, the patient's eyes are permanently closed. There's still no communication. Sometimes in the persistent vegetative state, you can get a partial response to external stimulation. Play a loud noise, the patient might show startle response. Pinch the skin, the patient might show some tearing, a reflexive pain type of response. But really, there are very few signs of emotion. The brain damage in the persistent vegetative state is in a different part of the brain than the brain damage in coma. In typical cases of the persistent vegetative state, the brain damage is in the thalamus, okay, not in the reticular formation, in the thalamus. We know that the reticular formation controls the sleep-wake cycle. So it makes sense that in the persistent vegetative state, you wouldn't have damage there, because if you have damage there, you wouldn't have a sleep-wake cycle, right? The way you get wakefulness without awareness is by having damage someplace else. And we now know from neuroanatomy that the reticular formation sends patterns of activation up to the thalamus, which are then distributed to the rest of the cortex, so that the reticular formation can be doing its job managing the sleep-wake cycle, but if its activation is not getting through the cortex, if the activation is not getting through the thalamus, then nothing's going to happen elsewhere in the brain. That's generally the logic here. So if you define consciousness in terms of awareness as opposed to wakefulness, then maybe you've got a different part of the brain that is the neural correlate of consciousness. Some of you have been reading about the minimally conscious state. This is a recent condition that is now separated from the persistent vegetative state. It turns out that some patients, though not all patients, in the persistent vegetative state seem to show some minimal level of consciousness. They are sometimes specifically responsive to environmental events. It's usually inconsistent, and it's usually a relatively weak response, but still you can see them responding to the environment. Sometimes they're able to follow commands. Sometimes they're able to vocalize yes or no, or gesture yes or no. They're sometimes able to respond appropriately to objects. If you put a mug within their reach, they'll reach for it. If they touch it, they'll grasp it. These are the kinds of behaviors that we would associate with consciousness. Moreover, these patients will show deliberate eye movements. If you move an object back and forth in front of their eyes, they'll follow it with their eyes. If you hold an object steady, they'll fixate on it. These are the kinds of things that are used in neurological tests to test for consciousness. Now, in the minimally conscious state, we also tend to have damage in the thalamus. Presumably, it's not complete damage. The thalamus has not been completely wiped out, but still, it's very extensive damage to the thalamus. Okay, so now we've got these two continua of consciousness: wakefulness, which seems to have to do with the reticular formation, and the awareness, which seems to have to do with the thalamus. You can see this even more clearly in another contrast known as the locked-in syndrome. People see the movie Awakenings Robin Williams playing Oliver Sacks, or the Iron Bell and the Butterfly. Good, really nice depiction of the locked-in syndrome. Patients with the locked-in syndrome are, for all intents and purposes, conscious. They are aware of what's going on around them. They simply can't respond voluntarily. There's a loss of speech, the function, and all of that. But we know that they have full consciousness because they show appropriate responses to stimuli. They show startle response and other reflexes. They're not inconsistent in their localization, the visual pursuit and localization. They can do it any time you check it. Got preserved emotional response. Here in the locked-in syndrome, the damage is in the pons and in the anterior portion of the brainstem, sparing the reticular formation, which is, if this would work, here, okay, and also sparing the thalamus. So again, by doing these kinds of neurological or neuropsychological studies with people who lie in different places on the continuum of consciousness, comatose, persistent vegetative state, minimally conscious state, the locked-in syndrome, or whatever, we can hope by these neurological analyses to hone in on those portions of the brain that are particularly important for consciousness. That's the general idea behind this logic. Yeah? No, in the locked-in syndrome, you don't need any particular machinery to stay alive. Those functions are being performed by the lower part of the brainstem, and for that matter, other portions. They're just spared, so their vegetative functions are intact. Yeah, they just are not able to move, and the reason they're not able to move is that projections from the motor areas of the cortex down through the spinal cord to the limbs of the body pass through the pons. Okay? So if the pons is damaged, that's it. It's like there's a roadblock there. What don't get controlled are certain, not all, but certain cranial nerves that control parts of the facial musculature, so that you can get some certain kinds of eye movements, for example, even with damage to the pons, because the cranial nerves that control the movements of the eyes don't pass through the pons. Okay, but in terms of vegetative functions, they're fine. Okay, and that's for that matter, that's true in coma as well. You have to hydrate the person. You have to give them nutrients because they can't eat, right? But in terms of breathing and all of that, that just goes on naturally. That's because those are all essentially brainstem functions. Well, that's a serious legal and medical issue. You can pull the plug on somebody in a coma. You can pull the plug on anybody as long as they're plugged in, and you have the right to do it. But these are serious issues. And one of the things that makes them serious is this question of maybe the person is conscious and we just don't know it. Okay? The minimally conscious state, for example, this is a relatively recent diagnosis. I mean, Giacchino only described this state in 2002. That's 10 years ago, okay? And if you pay attention to newspapers, you will every once in a while see a major legal case of somebody who's in a coma, been in a coma for a long time, or been in a persistent vegetative state for a long time, and for one reason or another, a relative says, look, it's just time to let this person go, right? And there are sometimes battles within families about this, and there are sometimes battles between family members and the state. There are very famous cases. I write about one at length in the lecture supplements. And one of the things that Stephen Loris, this Belgian neurologist that I've been talking about, become quite famous for using brain imaging technologies to try to get objective evidence about whether a person is conscious or not. Because again, you ought to be able to get evidence of consciousness if you're going to claim that the person's conscious. But if they can't communicate to you, how do you do that? Okay? Well, one of the ways that Loris has devised, I'm getting ahead of my story here, but that's life in this class. One of the ways he's devised is to put a person, well, you can do it with EEG, or you put the person in a brain imaging device, fMRI magnet, and you have the person imagine watching a tennis match, okay? And it turns out when you imagine watching a tennis match, or you imagine or you try to reach for something, there's activation in the primary motor cortex and in the premotor the cortex. So you can use that as a signaling device, right? To get the person to be able to respond yes or no. It's very, 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 very interesting. But it doesn't occur in all cases. The latest figure I think I've seen from Loris is that in fewer than 20% of cases of the persistent vegetative state do we see anything remotely resembling consistent evidence of conscious awareness, okay? For the other remaining 80+%, you got no help at all. So the patients are not just unresponsive behaviorally, they're unresponsive in terms of these covert behaviors that you can measure with physiology. Is that a response? Okay. Anything else about this? Yeah.
So the persistent vegetative state comes after a coma?
It can come after a coma. You don't go right into the persistent vegetative state. Usually it's part of the recovery process. For many comatose patients, the recovery stops there. Okay, some comatose patients will just die in coma. That's just the way it goes. But at some point, typically within about a month of first entering the coma, what you can begin to see is the patient's eyes will open. And people say, oh, he's awake, right? Well, maybe not, you know. And then you'll see the person go through the sleep-wake cycle and all that. That's the transition, what appears to be a sleep-wake cycle. That's the transition from coma to the persistent vegetative state. And sometimes the persistent vegetative state doesn't persist and people can come out of coma. You read about these cases from time to time where somebody's been in a coma or, well, even the PVS, persistent vegetative state, wasn't diagnosed until relatively recently, okay? So you'll get these cases of people who are allegedly in coma, they were probably in a persistent vegetative state, and then they come out and they've got some ability to function consciously. This is very rare, okay? It doesn't happen all the time. It doesn't happen even remotely resembling lots of the time, but it does happen. And that's why it's such a profound medical ethics issue, you know? And it's one where technology, if we had a proper definition of consciousness, and if we had some clear idea where in the brain consciousness resided, we might actually be able to address this very complex medical legal issue. Yeah. No, people in induced comas. People in induced, the whole point of inducing a coma is to render the person unconscious for a while. There are good reasons for that, good medical reasons, usually to promote recovery from brain damage. It's kind of paradoxical. But the clearest example of an induced coma is general anesthesia, which is very close to that. And I want to talk about that later on. We're going to have 2 days of lecture on anesthesia and coma, and we're going to talk about what we know about cognition and anesthesia and all of that. But the clearest example is general anesthesia. Which is quite different, for example, from what some of you may have experienced in the doctor's office with what's known as conscious sedation. If you have had arthroscopic surgery on your knee, for example, some of you athletes may have had this, whatever. They don't put you out completely. They give you a series of sedatives, drugs like propofol, that induce what's known as conscious sedation. You don't feel any pain, you're wide awake, you can interact with the surgeon, but when the procedure is over, you really have very little memory of this. So you've been awake, you've been conscious in that sense, but you don't have any conscious recollection of the procedure. It's a very, very, very interesting kind of thing to go through. Yes, one more question, then I got to go on.
Is it known if people in a state of Bachman syndrome are able to experience physical pain?
Yeah, it's known largely by inference because they show the physical signs of being in pain. If you take a flap of skin and pinch it between your two fingernails, they'll show some tearing, for example, which an autonomic response. They might show some flushing of the face or whatever, which are behavioral signs that would lead us to infer that somebody was in pain. But they can't say, ouch, you're hurting me, you know, because they can't communicate like that. They might be able to communicate with eye movements. So you might be able to say, when you feel pain, move your eyes up and down, or move your eyes, better yet, move your eyes to the left or the right. That's how you would communicate with these people. Who's seen The Iron Bell and the Butterfly? Okay, so you know how that guy wrote his book, right? He basically did it by directing his eye movements towards a tablet that had letters on it and dictated his book letter by letter. You know? You can do that if you want. So you could just as easily have said, are you in pain? Are you in distress? Do you want me to pull the plug? You can do all sorts of things like that. Once you've established a medium for what's essentially yes-no communication. You're not going to get the person reciting poetry. Okay, that's not going to happen. But in terms of yes-no communication, that's exactly what you do. Okay, so let's just pursue this thought a little bit more. You got the locked-in syndrome. Suppose we identified consciousness with attention, that we are conscious when we attend to things. We become conscious of things by virtue of paying attention to them. The connection between attention and consciousness is one that has a very long history in psychology and philosophy. And we know a lot about how attention works in the brain. It's not a matter of the reticular formation or the thalamus or the pons or anything like that, but rather there appear to be a set of networks. This is Michael Posner's theory of attention, which will do just fine for the purposes of this lecture, arguing that attention has three components. You're alerting to an event in your environment, you are orienting to an event in your environment, and then you're processing that event. Three different components of attention. And Posner has argued basically that there are three different networks of brain structures, the brain modules that are involved in each of these. So again, if you say, well, consciousness has to be more than just wakefulness, it has to be more than just awareness, it has to be paying attention, then you start moving elsewhere in the brain and you start looking at these networks in the parietal lobe, for example, or in the frontal lobe, in the anterior cingulate gyrus, as a place where you might find the neural correlates of attention. Again, that's the logic. Here's another neurological syndrome that's related to attention, a syndrome known as unilateral spatial neglect, often found in stroke patients. And what happens in these patients is that they seem to ignore objects that are in one part of space, typically that part of space that is contralateral to the site of their lesion. This usually happens with people with right hemisphere lesions, so what they tend to do is ignore the left part of space. If you draw a line, do I have chalk? If you draw a line for the patient and you say, draw a line, a vertical line that bisects this line, cuts it directly in half, patient might put it there. It's as if they don't see that part, right? So again, you could say they're not aware of that part of space. What's going on with that? And the answer is, in these patients, there is usually damage in this portion of the cerebral cortex in the right hemisphere. Why this isn't in the left hemisphere too, I don't know, but those cases are very rare. In the junction of the temporal parietal, and frontal lobe, right about there. So again, if you think about awareness and attention in terms of the lack of it that's shown by patients with unilateral spatial neglect, then you might start thinking that that region of the brain is somehow crucial for consciousness. Yes?
Is this concept completely different from the phenomenon that occurs sometimes with Parkinson's patients, in which they're unable to cross imaginary lines until someone visualizes it or helps them visualize it?
I don't know that much about Parkinson's disease, so I wouldn't, it sounds right, okay? But Parkinson's disease has its neurological substrates in a very different part of the brain, is my understanding. So I just wouldn't want to say. I could try to find out for you. We've got 2 neurologists in the psych department, and there's always Wikipedia. But I just don't know, and I wouldn't want to give you a misleading answer. I think in some advanced stages of Parkinsonism, you can also get something very similar to the locked-in syndrome.
Yeah.
But again, yeah, that's it. That's my knowledge of Parkinson's disease. Okay. All right, so again, the logic here is you find patients that have some kind of defect in what you're willing to call consciousness, and then using brain imagery or the imaging or whatever, you try to find out if there's a specific piece of brain damage associated with that area. So again, just to follow this up, you might want to identify consciousness with working memory. Not exactly short-term memory, but what we now call in psychology working memory, which is what you're working on right now cognitively. When I'm lecturing, I've got in my working memory the point I'm trying to make now and the next point I'm trying to make and all of that. You're doing something very similar. All that stuff is in working memory. If I'm conscious of something, that something is somehow being represented in and processed by working memory. So where's working memory in the brain? Well, again, it turns out that we have 2 different forms of working memory, spatial memory and verbal working memory. I don't want to get into that, but these tend to be mediated by different kinds of different brain structures, different brain modules. So again, if you're going to define consciousness in terms of working memory as opposed to attention, well then, here is where you'd start looking for the neural correlates of consciousness. How you define consciousness is going to determine where you find it in the brain. Here's another example, okay? If you think about consciousness in terms of qualia, that is the difference between seeing something and hearing something, or the difference between seeing red and seeing blue, we know that those conscious mental states are generated by certain parts of the brain. The auditory projection area in cerebral cortex, for example, or the visual projection area in occipital cortex. So if you want to think about visual consciousness, then you want to start looking at area V1. If you're talking about auditory consciousness, then you want to start looking at area A1. And so on. Here's a dramatic example of this. We have a distinction in memory between 2 expressions of memory, explicit memory and implicit memory. Explicit memory is conscious recollection. It's what you do when you recall or recognize something from your past. Implicit memory refers to any effect of a past event on a person's subsequent experience, thought, or action. It can be not just recall or recognition, but just any form of learned response. And we now know that in certain neurological syndromes, that these 2 aspects of memory, these 2 expressions of memory, explicit conscious memory, implicit unconscious memory, can be dissociated. That is, you can have implicit memory in the absence of explicit memory. People can show priming effects, for example, without being able to consciously recollect the prime. These patients like patient HM, are not consciously aware of their past. So they lack consciousness in that sense. HM was consciously aware of what was going on around him at the time, but he had very limited conscious awareness of his past. And we now know that HM and other patients like him had damage in a particular part of the brain, the hippocampus and surrounding portions of what's known as the medial temporal lobe. So now if we think about conscious recollection, then maybe the hippocampus has something to do with that. That's where we're going to find the neural correlate of that aspect of consciousness. Similarly, if we think about blind sight, another syndrome I'm going to talk about in a little bit more detail later, these blind sight patients have a scotoma. They have a blind spot in their visual field, maybe the upper left quadrant or whatever. It doesn't matter what it is, but they see nothing in it. If you present an object in there and you say, "What do you see there?" "I don't see anything. Remember, I've got a blind spot there." But if you now ask them to make a guess about whether there is an object in their blind spot or not, whether it's moving or stationary, whether it has a certain gross form or not, these patients can make judgments about the object that are accurate better than chance. Not perfectly accurate, but accurate better than chance. This is a phenomenon known as blind sight because they seem to have some visual processing, but does not give rise to the conscious experience of seeing. And we now know that blind sight occurs with damage to a particular portion of the primary visual area, area V1 in the occipital lobe. So again, if you want to think about what's the neural correlate of conscious seeing as opposed to unconscious seeing, then you start looking in area V1 for the neural correlate of that aspect of consciousness. Where we find the neural correlates of consciousness is going to depend on how we define consciousness. Okay, that's the general point here, which I'll make just, well, here's an example of a somewhat different approach from my former colleague Dan Schachter, who once proposed that in addition to all the other processing modules that are in the brain, there's a particular module that Schachter called a consciousness module. Okay? And so that if you had communication between the consciousness module and, say, a module that performed the visual the processing, then you were conscious of what you were processing visually. If you had communication between the consciousness module and an auditory processing module, then you could consciously hear things. But if there was a disconnection between if there was damage to the consciousness module, or if there was a disconnection between the consciousness module and this other module, the other processing module could go on and do its work outside of conscious awareness. Again, another approach to finding the neural correlates of consciousness. Schachter no longer believes this, okay? But it was a good idea at the time. The reason I'm pointing it out to you now is that it's exactly the kind of way you would approach this from the point of view of cognitive neuropsychology and cognitive science. First, you find out what the brain does, and then you look for what part of the brain is doing it. And it might be that there's a whole module down there. It's very common to think about the brain as a collection of task-specific processing modules. Maybe there's one for consciousness. Maybe it's in the pineal gland. I mean, I don't know, you know. But it's not outside. It's not outside the realm of possibility. And then finally, these are PET images collected by Hannah Damasio for a New York Times Magazine article some years ago. The idea is that through brain imaging, whether it's PET imaging, old-style PET imaging, or more recent functional magnetic resonance imaging, you ought to be able to find the neural correlates, the particular patterns of neural activity that correspond to particular thoughts, feeling anxious as opposed to feeling pleasure, feeling perceiving something as opposed to remembering something or whatever. And the general idea here is that again, if you think about consciousness in terms of, having particular conscious thoughts or feelings or desires, then if you believe anything remotely resembling the identity theory, then you ought to be able to find a pattern of neural activity that corresponds to that particular thought, feeling, or desire. Okay, we're going to skip that. Here's just a signpost, kind of a summer reading assignment if you want. Berkeley's Alva Noe has suggested that the search for the neural correlates of consciousness may in some sense be misguided because, as Noe has provocatively suggested, then consciousness may not reside exactly in the brain. Okay, here's the basic quote from Noe. Consciousness requires the joint operation of brain, body, and the world. And the general idea here is you're not conscious unless there's something to be conscious of. Okay, so yeah, you have to have a brain to be conscious. The brain may be necessary, but it is not sufficient. You've got to have some target for your consciousness. Just a little reminder, I think, that the search for the neural correlates of consciousness will take you may take you only so far. Okay, so that's basically all I have to say about the first mind-body problem, which is to say, how do bodies generate minds? The answer to that is typically formed these days in terms of what's known as the search for the neural correlates of consciousness, samples of which I've just given you. Sometimes people mean a little bit more than that. David Chalmers, in the book reviewed by Searle, for example, spends a lot of time talking about the search for the neural correlates of consciousness as the easy problem of consciousness. That is, you find somebody who's comatose, you wait for them to die, you autopsy their brain, you find out they didn't have a reticular formation, and you say, there it is. That's the neural correlate of consciousness. It's pretty easy in principle. Chalmers has argued that the really hard problem of consciousness is to figure out how those brain parts produce it. How is it that the reticular formation generates subjective feelings of wakefulness, for example? Or how is it that the thalamus generates subjective feelings of awareness? That's what Chalmers thinks of as the hard problem of consciousness. And then there's another version of the hard problem, which Chalmers also talks about. Is why do they do that? Why do brains do anything more than process information, take inputs, and generate outputs? Why can't that all go on in the dark, Chalmers' phrase? Why doesn't it all go on unconsciously? What's the point of being conscious of these kinds of things? These are indeed hard problems, and I don't think I'll be able to solve them here. Maybe in the last lecture, give you something to look forward to. But no, I won't be doing that. But the point here is that right now, the scientifically tractable problem is what parts of the brain do it? What aspects of neuroanatomy and neurophysiology seem to be so closely tied to the vicissitudes of consciousness that we can say that that's where consciousness is generated? How a pattern of neural firings produces the subjective experience of red or hunger or anger or something else, that's another question entirely for people to look at. Yeah? Well, how would it go on in the dark without being conscious? Well, that raises an interesting question of whether consciousness actually buys you anything or not. Okay? And if you'll remember McGinn's 4 aspects of conscious shyness that I talked about in the very first lecture, he says, well, one thing is conscious inessentialism. There are people out there who say, well, we are conscious, but consciousness isn't necessary for various kinds of various kinds of functions. And then, kind of taking one step further, there are those epiphenomenalists who say that consciousness doesn't do anything at all. So if you think about the mind as an information or the brain, either one. If you think about the mind or the brain as an information processing machine that generates inputs, I took your question, and I worked on it with an algorithm, right? And then I generated this response. There isn't any particular reason why that couldn't be done unconsciously. You see the ads on television for the Roomba, right? The little vacuum that runs around your room, and when it encounters an obstacle, it backs off and it goes off in another direction, and pretty soon it's sucked up all the dust bunnies on your floor. Nobody thinks the Roomba is conscious, but it performs all sorts of really cool information processing functions. So does your smartphone. So does your computer. Why don't we just, if we think that the mind is basically some kind of computer, which is a very common way of thinking about the mind, there's no reason why those input-output functions couldn't go on, leading me to avoid obstacles when I'm walking without necessarily being conscious of them. So that's it. Why doesn't it all just go on in the dark? What does it buy us to be conscious? Now, there's a question that's worth thinking about. What is the benefit of consciousness? Is there anything we can do by virtue of being conscious that we could not do by virtue of being without it? Yeah? I think the answer to that's self-evident, but apparently it isn't, because there are lots of people who argue that consciousness is epiphenomenal and it doesn't buy us anything at all. But again, one of the legacies of the computer metaphor of the mind, which, as Searle reminds us, is an extraordinarily powerful metaphor in psychology and cognitive science. Seymour Papert describes the brain as a machine made out of meat, right? One of the founders of artificial intelligence, this whole idea that is just a mechanistic process of processing inputs and generating outputs, it seems as if that's something that you could do without consciousness. So that's why Chalmers thinks that's a hard question. Why doesn't it just all go on in the dark? If you're an evolutionary psychologist, what's the adaptive benefit of being conscious? Ooh, a final exam question. Okay, let's start out here for a second by flipping the mind-body question around and asking basically its reverse, which is, how do minds affect bodies? So far we've been talking about how bodies affect minds. You got a reticular formation, you can go to sleep and wake up. You got a thalamus, you can be aware of some things. How do minds affect bodies? This is a question raised really nicely by Sigmund Freud. This is the only time I talk about Freud in this course. Which is how it is that you get from a mental process to something going on in your body. That's something that is not, he thinks, just as incomprehensible as the reverse. How do we get from a pattern of neural findings to a conscious mental state? This comes up in the context of what's known as psychosomatic medicine. The idea that beliefs and feelings and emotions and motives and desires and all of these kinds of things can have somatic consequences. Notice how I put that. Your beliefs can have somatic consequences. Beliefs cause bodily changes. Franz Alexander epitomizes this kind of mid-20th century in what I think of as the psychoanalytic legacy. Alexander, being a good Freudian, argued that unconscious conflicts of various kinds express themselves in bodily disease, okay? So that you weren't aware that you wanted to kill your father and sleep with your mother and all these kinds of things. But the fact that you did want these things unconsciously led there to be certain kinds of bodily changes. So, for example, Alexander argued that anorexia nervosa, common eating disorder, was related to unconscious feelings of envy and jealousy. Peptic ulcers were related to infantile dependency. Asthma, bronchial asthma, bronchial asthma was caused by excessive unresolved dependence on one's mother. High blood pressure, chronic inhibited aggressive impulses. Unconscious aggression led to high blood pressure. And rheumatoid arthritis, okay, was caused by unconscious rebellion against your parents, in which case every one of you here would be in serious trouble, right? Because you're at a certain age, the whole point of being that age is to rebel against your parents. But remember, it's not conscious rebellion. Conscious rebellion, you're fine, right? It's unconscious rebellion, right? This guy is a psychoanalyst. So here's Alexander's famous explanation of how peptic ulcers occur. You start out here with you're being taken care of. There are feelings of infantile dependency, which lead you to have inferiority feelings, and then you try to overcompensate for these inferiority feelings, and the whole thing generates gastric flow of gastric juices, which eat away at the lining of the stomach and give you a gastric ulcer. That's the process for psychosomatics. More recently, there's a modern psychosomatic formulation for this, which simply is that ulcers are caused by stress, right? And there's a whole process in the autonomic nervous system for knowing about this. It's something you learned about in Psych 1 if you took Psych 1. And that is still a common popular notion about ulcers, which is that they are caused by stress. A popular notion that was undermined by the work of two Australian physicians, Marshall and Warren, who discovered that the guts of people with ulcers were full of a particular kind of bacterium known as H. pylori, Helicobacter pylori. That's what it looks like. It's a cute little guy. And they argued that wasn't stress that caused ulcer, it was this particular bacterium. And they did famous medical experiments. Marshall swallowed a whole vat of H. pylori to show that it caused ulcers, and the antibacterial treatment of H. pylori gets rid of ulcers. They got the Nobel Prize for this in 2005. It's really good medical work. I mean, these guys deserve the Nobel Prize, and they knew that they deserved the Nobel Prize. For decades after they published this discovery, they met for dinner the night the Nobel Prize in Medicine would be announced, waiting for the phone call, right? And they eventually got it. This was a great advance in internal medicine. So if you look at percentage of patients who have H. pylori infection, patients with ulcers, way more than normal. That's the general idea here. Now, what was interesting about this is that as soon as this the discovery was announced, people began to cast aspersions on the notion that stress had anything to do with it. Here's a quote from Stephen Hyman, then the director of the National Institute of Mental Health. He's now the provost at Harvard University. The time-honored attribution of symptomatic ulcers to stress alone may result from a theory-driven retrospective falsification. When an ulcer occurs, prior stressors are sought and blamed. He says, it doesn't have anything to do with stress. It's all a matter of H. pylori. And then the title of the article was, "Another One Bites the Dust." And what he meant by that was, here is another step forward in medical science, getting rid of psychological causes in favor of biological causes, arguing that if we really want to make an advance in understanding mental illness, what we ought to look at are the real biological causes of illness, not the unreal mental causes of illness. An idea that is reminiscent of the Churchland's idea that the findings of psychology ought to be grounded in the real world of neuroscience. Not so fast, we'll say, but I'll leave that until next time. Thank you very much.